It's my pleasure to introduce Dr. Sant Chawla, who will present the results of randomized phase 2b trial comparing first-line treatment with Aldoxrubicin versus Doxorubicin in patients with advanced soft tissue sarcomas.
Thank you. Good morning. Today, I'll be presenting a head-to-head comparison of randomized phase 2 trial of first-line treatment with Aldoxrubicin versus Doxorubicin in patients with advanced soft tissue sarcoma. In this study, we found that Aldox was significantly superior to Doxorubicin in response, PFS, and lacked the cardiac toxicity in spite of high-dose cumulative anthracycline. So Aldoxrubicin is
It's my pleasure to introduce Dr. Sant Chawla, who will present the results of randomized phase 2b trial comparing first-line treatment with Aldoxrubicin versus Doxorubicin in patients with advanced soft tissue sarcomas.
Thank you. Good morning. Today, I'll be presenting a head-to-head comparison of randomized phase 2 trial of first-line treatment with Aldoxrubicin versus Doxorubicin in patients with advanced soft tissue sarcoma. In this study, we found that Aldox was significantly superior to Doxorubicin in response, PFS, and lacked the cardiac toxicity in spite of high-dose cumulative anthracycline. So Aldoxrubicin is actually Doxorubicin with a linker. And this linker covalently binds albumin in vivo and then transported to the tumor, which has leaky media as well as acidic, and get dissociated, depositing high amount of Doxorubicin to the tumor. Pharmacokinetically, it's a long half-life of 20 hours, and very small amount of less than 2% is in the form of free Doxorubicin. In our initial pilot phase 1-2 study, 13 sarcoma patients, soft tissue sarcoma patients were enrolled. All of them had received previous chemotherapy, and the shown with the asterisks had also received prior anthracycline. We observed high response rate of 38% and long PFS and overall survival as shown. In the current study, we enrolled 123 patients. The randomization was 2-to-1. Aldox was administered in dose of 350 milligram per meter square, which contains 260 milligram per meter square of actual Doxorubicin per course. Doxorubicin was given in standard fashion of 75 milligram per meter square. Initial plan was to give 6 cycles in each, and cycles repeated every 3 weeks with the growth support in both arms. This is the patient's characteristics, which are well balanced in both arms with the age, sex, race, and ECOG. Please note the last column. The median cycles administered in Aldox arms were 6, with cumulative Doxorubicin dose of 1,500 milligram per meter square in about 70% of the patients. In the Doxorubicin arm, median number of cycles were administered were only 4 due to premature progression of the disease, with cumulative median dose doxorubicin 300 milligram per meter square in about 55% of the patients. Histological subtypes in both arms were well matched as shown and are typical of any soft tissue sarcoma study. This is the PFS results, as all PFS response criteria and duration of response were evaluated by the site as well as by blinded review, blinded independent reviewers. In next few slides, I'll show first the site review, and the lower column will be shown by the blinded central review. So PFS in the Aldox arm was 8.4 months, while in Doxorubicin arm was 4.7 months by the site review, which was highly statistically significant. In the lower column, as shown by the independent review, the PFS was still superior to in the Aldox arm, although the duration of both arms was slightly lower, but the magnitude of difference was similar. This is the Kaplan-Meier curve by the site review. As you see, the curve separates early, and there is a tail end of non-relapsing patient in Aldox arm of about 20% of the patients. The improvement in PFS was 3.7 months with hazard ratio of 0.4 with p-value as shown. This Kaplan-Meier curve is by the independent blinded review, showing the same shape of the curve and a similar improvement in the PFS, and it is also significant. PFS at 6 months is generally considered good indicator of anti-tumor activity of a new drug. We saw that in Aldoxrubicin arm, PFS at 6 months was 68%, while in Doxorubicin arm was 36% with significant p-value as shown. This was by the site review. Similarly, with the independent review, showed superiority of PFS at 6 months in Aldox arm, and which was also statistically significant. Overall response rate by the site review showed complete response in Aldox arm of 2.4, partial response was 19% with overall response over 20%, while in the Doxorubicin arm, the response rate was only 5%. I think it is a little lower and maybe reflection of the small number of the patients. By independent review, the overall response was again more than 20% in Aldox arm. Somehow the independent review are more stricter, and they didn't think that one patient partial remission qualified. This is a waterfall plot showing the anti-tumor effect and regression of the tumor, and truly reflective of the anti-tumor activity of both drugs. By the independent review, by the site review, Aldoxrubicin 64% patient had showed tumor regression, while in the Doxorubicin arm, 40% patient showed tumor shrinkage. This is by the central blinded review, similar waterfall graph where 60% had tumor regression while 40%, they are almost identical by both reviews. And this is more reflective of the anti-tumor response of both drugs. Then we compared our data to the recently published EORTC study. Both studies were reviewed by the site review. Both had control arm of Doxorubicin in the same dosage. And as you note here, the PFS is similar of 4.7 and 4.6. And the response is also 5 to 13% in both arms. Please note that in Aldoxrubicin, the PFS of 8.4 is similar to the combination of doxorubicin and ifosfamide of 8.4 and 7.4 months. Similarly, overall response was over 20% in Aldox arm, which is similar to the combination of doxorubicin and ifosfamide. This indicates to me that Aldox single drug can provide the PFS and response similar to the combination of full dose of ifosfamide and doxorubicin. These slides indicate the side effect. We noted slightly higher incidence of neutropenia in the Aldox arm, but overall serious neutropenic fever and other side effects were similar in both arms, except slightly higher incidence of nausea and vomiting and mucositis in the Aldox arm. As we all know, cardiac toxicity is the most important toxicity of anthracyclines. Please remember that in Aldox arm, we administered over 1,500 milligram per meter square of median dose in this patient population, while only 300 milligram per meter square median dose in the doxorubicin arm. We see here that reduction in LVF, 10 points or 15 points, was higher in standard doxorubicin arm. Also, more clinically relevant, no patient in Aldox arm had LVF reduction less than 50%, while in doxorubicin arm had 6% of the patient had reduction in LVF less than 50%. Please note that no patient in the doxorubicin arm exceeded cumulative dose of 450 milligram per meter square, so we don't expect any patient developing serious cardiac toxicity. No patient developed clinical congestive heart failure in either arm. In conclusion, Aldoxrubicin showed significant and superior PFS, response rate, and significantly lack of cardiac toxicity in spite 5 times the dosage administered. Also, Aldoxrubicin was similar in response and PFS prolongation to the full dose doxorubicin and ifosfamide. The toxicity were similar, and I think Aldoxrubicin may serve as a new adriamycin in the future. Finally, I want to thank all the investigators who contributed to the study, all the patients and their family, my team member, Dr. Chua and Dr. Sankla, and team members from Citrex, Dr. Levitt and Dr. Wieland. And thank you very much.